Good evening, everyone. Welcome to our Yashoda Masterclass, Yashoda Critical Care Webinars, Tuesdays webinars. We bring forth the sessions every Tuesday. Alternate one Tuesday, we bring forth Masterclass, which is helpful for students. And 1 week, we bring forth the sessions which are interesting, like interesting cases or interesting topics. So this week, we are going to have an interesting case where we dealt with in our hospital at Yashoda Malakpet. So I'm Dr. Kaladar. I'm head of the Department of Critical Care Medicine at Yashoda Hospitals, Malakpet. So this sessions, actually speaking, since almost 5 years and more than 5 years, we are without any interruption in between, we are bringing these sessions. And the mastermind behind, I think everybody know Dr. Venkatraman Kola. And because of his motivation, we are doing it continuously with our teamwork possible. So without much delay, I will, today's topic for discussion is from fire to flow. Basically, it is an ECMO in a case of inhalational burn injury, which is not very commonly seen in critical care setups, because we do see sometimes burns and all, but inhalational injuries sometimes coming with the severe ARDS may not be that regular. But nevertheless, these cases are very important, and especially timely intervention, because it can cause severe pneumonia leading to severe ARDS, and inhalational injury itself leads to severe ARDS, and how to tackle. And from this case, I think we are going to learn all those things from our expert panelists who are going to join. Dr. Pranay Ojha sir. I think I will introduce the panelists. Dr. Pranay Ojha sir is I think everybody no introduction needed, I feel, because ECMO Society of India has been established since 2008, and before that itself in India is being forefront to run the ECMO program across India, and in Riddhi Vinayaka having a large research center, and across, I can say, international and national, has been traveled and he brought all that knowledge to us. And there are fellowship courses from ECMO Society of India. If you look at myself and Dr. Gautam, we did that and learned a lot of things. So he was a former president of ESOA and the director of the ECMO program there at Riddhi Vinayaka. He will be joining us shortly. So meanwhile, I will introduce others like Dr. Deepanjan Chatterjee sir. Sir is very senior. I think sir also doesn't need much of any introduction. He's a senior consultant and director at Manipal Hospitals, Kolkata. Sir is also former president of ESOI and very actively involved in ECMO, especially the physiology of ECMO. I think if we look at that lecture, we don't forget it. Very well illustrated, and that lecture I will keep on revisiting to learn a new. Every time I revisit, I get new insights. Thank you, sir. Thank you for coming on to our session, and we are honored to have you on our board, sir. Deepanjan, sir. So we have with our another expert panelist, the Dr. Yugandhar Bhattu, sir. So sir is actually with us. He's a clinical and senior intervention pulmonologist. We always go for him, and he rescues us in difficult situations. And this is the case where we had difficulty, and sir was there with us, because of which we could able to have a good outcome. And is very known here in almost, I can say, more than 10 years in Yashoda Malakpet, given a lot of services across from Yashoda Hospital of their population here. And is very well equipped with all interventional pulmonology procedures, and they have a separate suite for them. So I think with his expertise and what we dealt with in this case, he will bring forth that expertise, and we'll be learning from him. So without much delay, I will introduce the speaker, Dr. Gautam. He is the senior consultant at our hospital. He is post DRNB critical care, and we both were there in the night when we initiated the ECMO. So he will be presenting that clearly, like in a lucid way, so that after that discussion, probably we will take all the expert panelists' views on that. So Dr. Gautam, I think without much delay, you can start your presentation.
Good evening, everyone. I'm Dr. Gautam, consultant at Yashoda Hospital, Malakpet. Thank you, Venkatraman Kola sir and Kaladar sir and Yashoda Hospital for bringing me this case on this platform. Okay, without much delay, we will be going into the case details. So I would like to share a real case which we managed here in our ICU, a patient with an inhalational injury ARDS, because this is a very distinct ARDS phenotype. So this is a 31-year-old male who was previously healthy, presented to the ER with a history of exposure to the fire in a closed room at his residence, which led to thermal burns injury involving his face, upper chest, and both upper limbs, approximately 30% of the total body surface area, and high inhalational dose of smoke and carbonaceous material. He was being intubated at the referral hospital in view of airway edema and was referred to our center in view of worsening hypoxemia despite high FiO2. This is the initial X-ray, which you can see there is a bilateral haziness. In the ICU, his head to dome examination, he was conscious and obeying off sedation. There was a
Dr.
extensive
Gautam,
burn.
you shared your PPT, na?
Yes, sir.
Slides
sir,
not visible.
Slides
not
not
visible.
visible.
Sorry, sir. Sir, no visible, sir.
No.
No, not visible.
Sorry, sir.
Yeah, just share again.
Yeah.
Yeah, keep it full screen now. Yeah, now we are able to see. Yeah, Dr. Gautam, you are muted. Unmute yourself and make it full screen. Again, it's muted. Some problem with the sound. I think again muted. It looks like it's muted.
Sir, now, sir.
Yeah, now it's fine. Yeah, go for
I'm
full
sharing this.
screen.
Okay, sir. Is my screen visible, sir?
Visible. Yeah, now it's fine.
I'm
Go ahead.
audible also, no, sir?
Yes, correct.
Yeah, okay, sir. So he sustained a closed thermal burns injury with a high inhalational dose of smoke and carbonaceous material. He was initially intubated at the referring center in view of airway edema and was referred to our center in view of hypoxemia despite high FiO2. This is the initial X-ray where we could see a ARDS picture with bilateral fluffy shadows. In the initial assessment in the ICU, he was conscious and obeying off sedation. There was an extensive burns involving the face, upper chest, and both upper limbs, with singed nasal hairs and airway edema, with soot in the airways also. There was wheezing with bilateral crepitations on auscultation. The peripheries were very cool with and pulses were feeble. So he was resuscitated with the modified Parkland regimen, and the abdomen is soft with high colored urine. His initial vitals like heart rate of 125 per minute, blood pressure of 122 over 84, and saturating 92 with FiO2 of 100% and PRBC mode with settings 110, 28, and 320 FiO2 PEEP, respiratory rate, and tidal volume. His initial lab investigations were unremarkable, except there was some leukocytosis and uncontrolled hyperglycemia. His HbA1c was 9.4. He was a de novo diabetic at the time of the presentation. And the initial CT chest, it was showing multiple patchy confluent areas of consolidation and GGOs bilaterally, predominantly peribronchial, with bronchial wall thickening, suggestive of diffuse alveolar injury. So as the CT just it is showing the GGOs, and we had with the bronchoscopy, our interventional pulmonology team, they done a bronchoscopy which showed there was an extensive involvement of the airway mucosa with dense carbonaceous material and which is inflamed, and these findings are suggestive of abbreviated injury score of grade 3. Later we have done a ball aspirate, and I'm playing the video of the ball which we have done. We can see there was an extensive carbonaceous deposit with the sputum, with the inflamed mucosa and edematous mucosa on the bronchoscopy. So this is the bronchiole. There was an extensive deposition of the carbonaceous materials with soot in the airways. So these findings are consistent with abbreviated injury score of grade 3, which means it is a very severe injury. So after this, we went ahead with the Galveston protocol, that is the heparin nebulization at a dosage of 3,000 international units, along with N-acetylcysteine nebulization and IV corticosteroids to limit fibrosis and mucus plugging. And the ABG at this point, the pH was 7.16 with PaCO2 of 58 millimeters of mercury, PaO2 of 62, and bicarb of 16. That is, the PF ratio is 62. It is fitting into very severe ARDS. So we went ahead and we have done the prone ventilation for this patient. Why this inhalational injury ARDS is a distant entity means the pathophysiology involves both thermal injury as well as the chemical injury. The thermal injury, because of the direct heat at the supraglottic and upper airways, it will lead to the edema. Whereas the chemical injury, due to the inhaled toxins and gases, they will cause the surfactant loss with the capillary leak and collapse, which finally lead to airway edema and bronchospasm, and finally the diffuse alveolar hemorrhage. This all will result in refractory hypoxemia, reduced lung compliance, and sometimes they may lead to failure of the conventional ventilation, leading to severe ARDS. So before ECMO, we have optimized everything. Like we have went ahead with lung protective ventilation, targeting tidal volume of 6 ml per kg with P plateaus of less than 30, deep sedation with neuromuscular blockade, and the Galveston protocol like heparin nebulization, bronchodilators, and N-acetylcysteine, and bronchoscopic toilet to serial soot and cast clearance, and burn wound care with fluid resuscitation. Then a bone wound debridement was performed by the surgical team with collagen dressing application. Later in the post-operative period, the patient had refractory hypoxemia and hypercarbia despite appropriate lung protective ventilation. So at this junction, our team decided to go ahead with VV ECMO cannulation. So there was a refractory hypoxemia with severe ARDS, which was in response to the maximum conventional ventilatory support, where we took a call for the VV ECMO cannulation, and we performed a successful cannulation at 2 a.m. in the midnight. So during cannulation, there was our plan was like we divided into 3 teams, where team A took care of patient and ventilatory management, team B look at the cannulation, and team C for circuit priming and machine management. Our strategy was to go with the right internal jugular vein for return cannula and femoral veins for the drainage cannula. We have screened through ultrasound for the vessels, and we thought we will be placing 23 to 25 French on the drainage cannula and 19 French for the return cannula. And we used ultrasound guided Seldinger technique and transthoracic echo and chest X-ray for the position confirmation of the cannulas. And any procedure is without not without challenges. So we also face the challenges, like as he was a very obese individual, we had a difficulty in vascular access, especially the femoral, where we involved our vascular surgeon, Dr. Ranjit, for the cannulation, and it was successful. Like, and during the procedure also, there was a hypotension, which was effectively managed with colloids and also 2-packed PRBCs. The initial ventilatory settings, like we kept 2800 RPM, which gave us a flow of 3.2 liters per minute, and we kept the sweep gas around 5 liters with FiO2 on ECMO at 1. With the rest lung ventilator settings of FiO2 80 and 10 PEEP and 10 rate with the 10 pressure control. Our anticoagulation strategy was unfractionated heparin infusion, targeting an ACT of 160 to 200 seconds. And the monitoring, like we may monitor the patient like off sedation, the sensorium assessment, and ONSD, optic nerve sheath diameter, and hemodynamics and fluid balance optimization every hour, urine output, and watching for any hemolysis, daily chest X-ray to look at the cannula positions, arterial blood gases every 6 hourly, complete blood count, and renal function daily. Coming to the ECMO circuit monitoring, we monitored the pre and post oxygenator ABG, delta pressure, and we looked at any color changes in the circuit tubings to look for the recirculation, and daily visual inspection for the clots in the circuit. And we in between there was a stormy course, like we had a complications which we managed effectively. Like there was an AKI with Kirigo stage of 2, which was initially managed with aggressive IV hydration, later with prompt diuresis. And we had also heparin thrombocytopenia, where we switched over the anticoagulation strategy to bivalirudin, and there was test cardiomyopathy, which we managed with diuresis, and the infections with the MDR Klebsiella pneumonia and Aspergillus flavus. With this, we daily continued our routine fast track bit, that is the feeding, analgesia, sedation, thromboprophylaxis, head of the bed elevation, ulcer stress prophylaxis, glucose control, bowel regimen, indwelling catheters, and de-escalation of the antibiotics, and strict metabolic control. He had an episodes of accelerated hypertension and hyperglycemia. Both were effectively managed with both insulin and intravenous and oral antihypertensive, prompt fluid hydration balance status. And a serial bronchoscopy has been done by our interventional pulmonology team, which showed there was an edematous left upper limb and lower limb compared to right upper limb, with marginal improvement on the right side. This was the first bronchoscopy. This was done on the day 2 of the ECMO, and after that the patient had fever spikes, which we initially started him on BLBLI. Later we have escalated the antibiotics to meropenem plus sulbactam and linezolid. Later on the day 8, we can see there was an improvement in the bronchoscopy findings, and the ball culture has been sent for analysis where it grew MDR Klebsiella. So we have escalated the antibiotics as per the sensitivity patterns to tigecycline, ceftazidime avibactam with aztreonam, and there was also isolation of the aspergillus flavus. So we have switched. So we started antifungal therapy with voriconazole and anidulafungin, and stopped methylprednisolone also. So this is the culture sensitivity report where the Klebsiella pneumonia was detected, CTXM, NDM, and OXA48 was detected along with aspergillus flavus. So why we went with rapid diagnosis? Because burn ECMO patients are immunoparalyzed. They have a breached skin and prolonged inhaling devices. So they are a very high risk host for resistant and opportunistic pathogens. So this rapid molecular diagnostic shortened the time to appropriate therapy, while structured stewardship and therapeutic drug monitored. They will be helpful in maintaining this toxicity and resistance. And there was a continuous surveillance of the burn wounds, lines, and the ECMO circuit. As we anticipated that the patient requires a prolonged mechanical ventilation with ongoing ECMO support, a percutaneous tracheostomy was performed with fiber optic bronchoscope guided to ensure safe and accurate tube placement. So this is the X-ray post tracheostomy. In between, we saw a trend of thrombocytopenia. Initially, it was 1.8 lakhs to start with, where it dropped to 80,000 on the day 6. So where we had a clinical suspicion of heparin-induced thrombocytopenia, and we have sent the HIT antibody gel card technology, which uses lateral flow assay. So it turned out to be positive, where we have to switch over our anticoagulation strategy from heparin to bivalirudin by targeting APTT. So because hit on ECMO is the high stakes, like continuing heparin will be leading to catalytic thrombosis. So direct thrombin inhibitors like bivalirudin, they will be allowing us a safer anticoagulation strategy at these situations. While the initial echo was normal, we repeated a 2D echo, which was showed a global hypokinesia with moderate LV dysfunction, which was suggestive of Takotsubo cardiomyopathy. Because these patients, they will be having a high stress where there will be a catecholamine surge and myocardial stunning. So generally, it is reversible with the supportive care. So we carefully managed with the fluid balance optimization, initiating of the diuresis, and guideline-directed medical therapy. So with all this, once we met the readiness criteria that the native PF were adequate on the rest settings, and the plateau pressure was less than 25 with FiO2 of 0.5, and there was improved compliance with the clearing chest radiograph and resolving airway inflammation, which was seen on the bronchoscope, and with the background of hemodynamic status of the patient, which was stable. We daily assessed him for the weaning with sweep gas reduction trial and the PF ratios in the rest lung ventilation settings. So on day 7, we attempted our first weaning trial with by switching off the sweep gas, but the patient developed hypercapnia and had desaturation with tachypnea, tachycardia, and hypertension, where we returned back to our again to full ECMO settings. Then we looked at the causes. So we have optimized the cardiac status because he was having a stress cardiomyopathy. So we have carefully, meticulously managed the fluid balance status and optimized the fluid status. And we had treated the VAP aggressively with tigecycline, ceftazidime avibactam, and aztreonam along with antifungals. And we have we increased the nutritional support, and we actively mobilized the patient. After this careful optimization, we went ahead with the second trial on day 12th of the ECMO, where the patient tolerated no flow state for a period of 24 hours without any hemodynamical instability, and we were able to perform a successful decannulation on the day 12 of ECMO. So there was a liberation and early rehabilitation, where tracheostomy was performed for comfort and secretion clearance and weaning to gradually weaning to the spontaneous breathing with active, aggressive, and chest physio. with early mobilization and high protein diet for the nutritional support, and also the psychological recovery, because the patient had an episodes of nightmares. So because he underwent so much of trauma, so psychological counseling, so we took care of his sleep patterns, and we had a meticulous counselings with the family members and involved the family and patient both in the care. So we are able to manage the delirium part also. So once after all this, again our interventional pulmonology team, they assessed the upper and lower respiratory tract before decannulation of the tracheostomy tube. So at that there was a normal subglottic segment only with a minor granulation tissue, which made a hope that the patient can be successfully decannulated from the tracheostomy tube, except from residual mucopollulant secretions. So for which we continued aggressive chest physio. And finally, we were able to wean him to oxygen support via thermovent, where the patient tolerated well, and tracheostomy tube was removed on day 20 with no respiratory distress post decannulation, except he had some episodes of bronchospasm, which was managed with the bronchodilators and positive pressure ventilation with the BiPAP support. And we made him walked in the ICU with the physiotherapy team and discharged to a rehabilitation center in a clinically stable condition. So this is the X-ray post decannulation, the tracheostomy, and this is the X-ray 1 week follow-up, where we could see a progressive clearing of the infiltrates, which are consistent with the clinical improvement towards a full recovery. So this is the our team with the patient post decannulation, where we could see the smiling faces. So what these cases teach us? So as I already said, the inhalational injury ARDS is a distant entity, like it is a different phenotype of ARDS, because it involves both thermal injury as well as the airway chemical injury, which causes an alveolar damage. So here the burn size, skin burn size is like ARDS is more important than the skin burn size. And the bronchoscopy, it we use for AIS grading, where grade 3 and grade 4 we need to anticipate that the patient is more prone for ARDS, and we should be having with our backup plan apart from our conventional ventilatory strategies. And in this situation, always VV ECMO is a rescue. It buys time for the reversible lung, and timing is everything, because early referral was key in this case, because there was no multi-organ failure. Because if once a multi-organ failure has set in by the time the patient reaches a tertiary center, the window is very narrow, and the patients may become non-salvageable also. And we had a challenges where we had AKI, heparin-induced thrombocytopenia, stress cardiomyopathy. So all the infections which are which we managed effectively. So always teams win this in such type of cases. So even if you look at the literature also, they also guidelines, they define the VV ECMO criteria, configuration and circuit management. So, and ARSNet protocol allows us to it shows that lung protective ventilation is the foundational, and earlier trial, it signals like early VV in ECMO in severe ARDS has a good outcome, and CSAR trial referred to an ECMO centered improved disability free survival. And ATS, ESCM, and Society of Critical Care Medicine 2023 4 guidelines, they say have a conditional recommendation for ECMO in selected severe ARDS patients. So 7 things which I felt to remember on this case is early bronchoscopy is essential, because it helps us in grading the airway and clearing also, and also anticipating the ARDS, because great inhalational injury predicts severe respiratory failure. And lung protective ventilation, it remains fundamental before and also during the ECMO. We should not forget the basics, like lung protective ventilation is the first thing, and it is a fundamental thing. And don't delay VV ECMO, because you should refer the patient before any multi-organ failure sets in. And serial bronchoscopic toilet improves airway clearance, and it supports in weaning also. And you have to anticipate every complication like heparin-induced thrombocytopenia, bleeding, infections, acute kidney injury, stress cardiomyopathy. And early rehabilitation and multidisciplinary teamwork can convert survival into recovery. So timely recognition of severe inhalational injury, aggressive airway management, lung protective ventilation, early VV ECMO in refractory ARDS, and coordinated multidisciplinary care can convert an otherwise fatal illness into a successful recovery. And this is our success story. Thank you. Sir?
Thank you. Yeah, thank you, Dr. Gautam, for that nice presentation. I think this case beautifully illustrates that ARDS secondary to inhalational injury, if we treat early, like especially the role of ECMO, how it can be very helpful in making a difference in the outcome of the patients. I think with that background, we go for the panel discussion. Deepanjan sir? Hello. Yeah, Deepanjan sir. Sir, can you unmute yourself, sir?
Yeah.
Sir, yeah.
What's the role of heparin nebulization? Do you use it frequently, or what are the beneficial effects of heparin nebulization in these patients?
Yes, sir. I think before we go to that question, probably we'll start with our the initial part of the discussion, sir. So I think what I want to ask you is with this case. So what we learned is initially this patient came to us in a severe ARDS state. Especially he was presented to outside hospital where there was edema. And the one good thing they did outside is they intubated early rather than waiting for more time where it could have been a difficult intubation. So this patient, when he came to us, he was on the night itself, he was having severe ARDS. We tried, I think, 1 minute, sir. I think Dr. Pranay sir is telling he's joined. So, unable to unmute. 1 minute, sir. So that is when he presented to us, and we did one proning session. So next day there was some improvement in PF ratio, and we took him for this collagen application. So that is what happened, sir. Pranay sir, welcome, sir. Sir has joined.
Hi, Kalandar.
Yes, sir. Yes, sir. Thank you, sir. Thank you for joining. Just now we completed the discussion, sir.
Yeah, I was there in the last part of the slides, so I heard last slides.
Yes, sir. Yes, sir. Thank you, sir. So I was just talking to Deepanjan sir regarding so the timing of ECMO, because this patient initially came to us, sir. Then we did one prone session, and then we did a burn wound management initially. Then what happened is consistently was having ARDS, and the PF ratios constantly falling down to below 60. So in this context, what do you think, sir? The opinion about the timing of ECMO. Most of the times, like we discussed, that early is the better. But in the context of inhalational injury, what do you expect? Like what can happen, and do you think early is better, or otherwise go on for proning for some more sessions and wait for some time? Dr. Pranay, sir, I think.
See, I think inhalation injuries, they don't give much of a time. You know, if you try to delay it, probably they become more worse, and then the ECMO run probably might be for a longer time. If they do respond, they might respond to some extent to steroids, but otherwise no. See, inhalation injuries can be divided into like a smoke injury, what you say, or you can have an inhalation injury because of some poisonous gas. Okay. And in both, probably the etiology is going to remain the same. It's going to affect the airways, and then lot of secretions, they develop some edema, and then later stage it is going to form the cast, and the cast is the one which is going to trouble you. So eventually, these patients have been put on ECMO earlier, the better. In fact, sometimes they don't even give a time. We have a series of, in essence, poisonous gas injury, and some of the patients we have to just put them on ECMO doing ECP or something like that. So they may not give you much of a time. So you have to be ready to be there, initiate ECMO as early as possible. I think the criteria remains the same. PF ratio is less than 100. I think you should think about putting them in an ECMO rather than just think about giving up proning cycles. If the patient is stable, PF ratio is more than 100, you can think about it. If he's unstable, probably you have to think about going for an ECMO only.
Yes, sir. I think early is the better. As you said, I think the burn-related flame injury and systemic toxicity, or otherwise industrial exposure of sometimes chemical irritants, and they get inhaled. I think the pathophysiology, as you said, remains same. but invariably they may take some time. Probably early the ECMO is better, sir, as sir said. So the next question is Deepanjan, sir. So when we put these patients like on ECMO, especially when we look at the ventilation strategies, we go for rest ventilatory settings. So in this patient, we also had some stress cardiomyopathy, sir, initially, but luckily this patient was hemodynamically stable. So, what do you think, sir? Like the strategy point of view, ECMO strategy point of view, do you think is it better to go for VV ECMO, or you have to think beforehand that probably they may go into shock, and suppose there is a stress cardiomyopathy, you may have to go for V ECMO, or otherwise, what do you think about that? And what about your opinion on rest ventilator settings? Is it any different from the regular ARDS compared to inhalational injury
See,
related ARDS? Sir, Deepanjan, sir.
see, two things I just wanted to clarify. One is your cardiomyopathy sequelae came in later in the course of events. Once you have put the patient on VV ECMO and the patient was gaseous exchange was normalized, then you found that after a couple of days, then you find that the cardiomyopathy is has started. But the thing is that our primary aim of ECMO here is to maintain the gaseous exchange. To maintain that, VV ECMO is more than sufficient. Secondly, the cardiomyopathy, unless it is severe and it is not being able to be controlled with your medical management, only they consider about our circulatory support through the ECMO. Without, if it is not so severe, it is easily available in most of the patients with our VV ECMO, and if needed, an inotropic support or anything else. So here you managed your hemodynamics well, managed your fluid balance well. So that is why you did not need your VA. Even during the course of events, the patient's output has gone down significantly and inotropic support is being needed. Only then you think of VA. Otherwise, don't think of VA or convert to ECMO without these things. And secondly, the rest ventilator setting, what was the compliance of the lungs? Was it only the gaseous exchange which was impaired, or the lung compliance which had gone down significantly in this patient?
Basically the lung compliance has gone down significantly, sir. Yeah.
Then the rest ventilator settings, as we practice in VV ECMO, that applies. If the compliance is poor, always our target is to keep a plateau pressure of less than 5 and a driving pressure less than 15. That is our target. But in this patient, I think you have kept the FiO2 a little bit higher side. What was the rationale behind it?
Initially, sir, actually, I think initially we put like that probably for some hours, but later, we came down to 40-50% only. I think this was not displayed, but
Okay,
later.
Okay.
Initially, only we kept for 80, sir. Later, we de-escalated to 60% and 50% eventually also, sir.
Sure. Okay.
The another point also, sir. Suppose
So rest ventilator
because
is same as in for VV ECMO, if you have a tight lung, the rest ventilator settings are same that as you had applied.
yes, sir. So, Dr. Yugandhar Bhatt, sir, are you there?
Hello.
Yeah. Sir, the question to you basically, in the context of inhalational burn injury, as we did in our case, like the serial bronchoscopies. So, what do you think? How early is better whether it is to go for early bronchoscopy as the patient comes early, or do you think the patient has to probably stabilize for some time and do it? how it is different from a regular patient compared to inhalational burn injury patient to assess any airway injury. So the role of bronchoscopy.
Yeah, that was a nice question in terms of our role in this great journey from simple burns and serious burns to breathe the normal air. So early bronchoscopy has it scores better than the delayed bronchoscopy, which deals with the complication. Because early bronchoscopy, you can grade the severity injury, airway injury based on the abbreviated injury score, whether it is 1, 2, 3, 4. Because once it is more than 3 and 4, the mortality scores around 60 to 80%, apart from your lung compliance and all those things. And it is going to be give a long-term complications and aggressiveness management in terms of counseling wise, management wise, and prognostication, the complications, taking particularly patient family members into consideration, and it will be one of the evident and we can go for a early ECMO rather than waiting for the prone sessions of 2 to 3, which conventionally will go for with a routine ARDS panel. That is the most important point. So early bronchoscopy will save the complication and also will initiate the early ECMO.
Yeah. So I think, yeah, in that context, probably we will be able to understand what is the grade and how severe is the airway injury. Probably, and repeated lavages, if we perform, we can be able to remove the cast and all. I think that is one aspect probably I think we look at. And Pranay sir, so actually, Pranay sir, are you there? So in this patient, actually being having this patient with burns and put on VV ECMO, we were a bit worried about whether this patient lands up in sepsis, because the burns exposed surface is very commonly they are prone to get infections. So what do you think? Suppose this patient develops a septic shock, which may be very severe, and on the background of some stress cardiomyopathy, suppose on fourth or fifth day, what can we do, sir, to manage that septic shock with the PV ECMO in place with severe ARDS? Are there any thoughts like how we can go forward? Suppose if the extent of the burn injury sometimes more, this patient, I was actually a bit worried when we put a VV ECMO later, the patient can develop septic shock and all.
Yeah, that is quite possible. More see that is probably, as you said, that's possible after 4 5 days or a week or so, where they can develop secondary infection. But more than that, probably they might require they might end up with the inflammatory response and the fluid loss because of the burns per se. So that might be the cause for hypotension in that. Unless there's a involvement of heart to the extent that ejection fraction goes less than 30% or so, probably there's no point in going for a accelerating it to VVA. But if the ejection fraction goes less than 30, probably then you need to think about escalating it to the VVA ECMO. Coming to the first previous question to Dipanjan on initiating ECMO as a thinking ECMO as a VA ECMO to start with if there's a stress cardiomyopathy. I agree with Dipanjan, there's no need basically. Most of the time it is more of a metabolic induced cardiac depression rather than a stress cardiomyopathy. So it's better to go with VV ECMO only, and then if required, if there are definite indications, then switch over to VVA. Otherwise, probably just manage like in routine ICU management.
Yes, sir. As you said, I think initially it is all metabolic factor related and hypoxia related, bit stunning of the myocardium. Probably once we correct with VV ECMO oxygenation and all, probably it will improve. So most of the times that is a tricky situation, especially youngsters. They think whether to go for VA initially if there is some noradrenaline support and all. But that's a clear message from Pranay sir that probably the moderate doses of noradrenaline also we can go for VV ECMO and see rather than directly going for VA ECMO, not the stress cardiomyopathy, not very severe and all.
So in
Probably.
my case, series of 9 patients with a inhalation injury of poisonous gas, all of them required some mild to moderate amount of inotropes. But only out of 9, one landed up with VVA ECMO, that too on day 4 or day 5 because of secondary sepsis. But otherwise, all of them we could manage them with VVA ECMO only. and almost 70% survived in that.
Yes, yes, I think very good. The experience that you shared, sir. Deepanjan, sir, the question to you is regarding, as you were asking, about the role of the adjunctive therapies, especially in the context of inhalational injury, something like nebulization. So the N-acetyl cysteine and heparin nebulization. So what do you think is the your perspective, sir, on that?
See, I have not used heparin as a nebulizing agent ever, but in acetylcysteine you can definitely use. We frequently use it. Uh, what were your bronchoscopic findings in, was there any bleeding from the mucosal surfaces? Did you find anything there? I just
Yugandhar, sir,
wanted to
yeah.
know because it's a
Yugandhar.
inhalational injury. That's why I wanted to ask
There was no bleeding.
whether there was no bleeding.
More of carbonaceous material was there, sir, and it was like thick, crusty. And when we were doing suction, all black soot particles were coming out. So we were searching the literature, inhalational injury, especially the thermal inhalational injury, and with they call actually it as melanoptosis, like the black soot coming out, hemoptysis and melanoptosis. So the across different studies, some systematic reviews and some observation studies, they what they had given is you can try if there is no bleeding, yeah, as you said, inhaled heparin. They have looked at 5,000 versus 10,000, 6th hourly actually. In our case, we have given 5,000 8th hourly. So it actually will not have any systemic effects. The local effects, the crusts which are there, they will be broken down very well. So that with serial bronchoscopies, they can be sucked out well. And whatever the crusts, they don't migrate down to the alveolar level and will not form that atelectasis and leading to some pneumonia. So in that way, some studies they have shown even mortality benefit. One RCT has shown mortality benefit, and they have given a protocol like NAC with bronchodilator because NAC can cause bronchoconstriction along with NAC one alternatively with heparin. So that is the reason we searched in the literature and then we started. Yeah, previously also we didn't have idea that heparin can be given as a nebulization form.
There
After
is
this, we could learn that point. Yeah.
one thing.
Dr.
Yeah. So to Deepanjan sir, there is one randomized control study where 116 patients are randomized to double-blindedly with and without heparin and NAC nebulization, which will be effectively theoretically. It's not because results are not out and not so effective, but some benefits are there when the endpoint was ventilatory free days. So here it acts as an antifibrinotic agent, heparin nebulized. 56, half of the patients are divided into the case and control. All were intubated, bronchoscopic guidedly, abbreviated score was more than 2 in a inhalation injury like this scenario. So it was benefited in terms of early weaning from the ventilator, heparin nebulized. That study called a Hepburn study.
Yes, yes, yeah, correct. So that is the study that we felt like.
Is there any role in routine ARDS, pneumonia-induced ARDS?
No, sir. No, only inhalational burn injury where there are
Okay.
crust formation happening with carbonaceous
Only.
deposits. Then only we do it. Otherwise, regular.
Routinely, what we will give Mesna nebula installation through bronchoscopy when there is a sticky mucus which are going to cause a recurrent obstructions in a serial X-rays when patient got intubated in spite not relieving with the routine physiotherapy.
Yes, yeah. So,
And what about using hypernebs? Hyperneb is
3% 3% saline nebs.
Yeah, 3% saline nebs. Because that doesn't cause the bronchospasm that is caused by the N-acetyl cysteine.
Yeah, that is also one choice, sir. But actually, NAC will have that thiol group where they break down that disulfide bonds in the mucus. Most of the studies say it is better effective strategy probably to clear off the mucus, break down the mucus. So probably I think we can try 3% saline also. It also breaks down. But this is a unique mechanism of the NAC, N-acetyl cysteine. Probably that is the reason I think it's been, and that's the reason they recommended in the protocol give NAC along with the bronchodilator so that the bronchoconstriction will not happen. So that is how, sir. Yeah.
And how long did you continue this medication in this patient?
We have given for 10 days, sir, around 10 days. I think 12th day we could wean him off and liberate him from ECMO. So up to 10 days we have given. The study says 7 to 14 days. 1 week to 2 weeks you can give. So we have given up to 10th day. So later actually he was getting better and we stopped it. And there was this apparent thrombocytopenia also. That is the reason we stopped it. Even though they say systemic effects may not be that much, but we didn't want to take that risk. So that's when we stopped, sir. So coming to another question, sir, Dr. Pranay, sir, regarding anticoagulation strategy. So in this patient, two challenges I can tell where you can highlight, sir, your expertise. One thing is like initially, suppose this airway mucosal injury is so much, the possibility that the patient can go into airway mucosal injury. In that case, if we have gone on to ECMO, what would be the ideal strategy of anticoagulation and low dose versus totally going off heparin? One thing, and in this patient we had thrombocytopenia. When we suspected possible HIT and we sent HIT antibodies came positive. Oxygenator, there were very small clots. Luckily, patient could not develop any thromboembolic episodes. So, what do you think when there is a platelet drop? Because sometimes we don't know whether it is some ECMO induced, or some sepsis induced, some heparin induced. What is the thought process generally that comes to your mind, sir, when you are at the bedside?
See, when you start patients on inhalation injuries with an exposed, even the burns also along with that, usually we, if there is no active bleeding, then usually I go for a low dose heparin. We give initial small dose of heparin and we try to maintain acidity around 140 or so. Not going very high acidity. But if there's a bleeding actively, we can see then there are some potential place from there that which they can bleed. Probably we can go for heparin-free ECMO also. So you can just give a small dose of heparin to cannulate at the time of cannulation. But then after that, you can just keep heparin free ECMO and you can continue it for even a couple of days also. But then in that case, you keep a flow higher side around 4 liters or so. Coming to your next question about heparin-induced thrombocytopenia. See, heparin-induced thrombocytopenia is not that common. I'll say it's at least in Indian population is not that common. In fact, I must have seen it in less than 3 patients proven heparin-induced thrombocytopenia out of 500 plus cases. What I have done, so that the incidences are going to be less. But yes, if you prove that it's an heparin-induced thrombocytopenia, probably you have to switch over to bivalirudin or orgatoban, which I think the bivalirudin is more easily available as compared to orgatoban. So you can use any of the thrombin inhibitors. But again, when you are using thrombin inhibitors, you have to see to it K, you have to avoid slow flow because they don't work well with the slow flow. And you have to again look at how much is your bilirubin level and that triglycerides and bilirubin. So you have to just keep a watch on that.
Yes, sir. Yes, sir. Thank you, sir. Thank you for those insights. Deepanjan, sir, the question to you. So, in this patient, actually, when after I think 8th day, the patient X-ray actually rapidly got better, and his oxygenation was also improving after 3-4 days. That's when we thought that probably we can wean him off VV ECMO and liberate him. So we had given a 24-hour trial also without any sweep gas, and even the FiO2, everything turned off to minimal possible. And he was maintaining. So when we counseled the patient attendants that we are going off ECMO, and after counseling, within 1 hour again he worsened. The thing is, he developed bronchospasm actually. So then he worsened, his CO2 went up, the oxygenation came down. Probably this is a bit of sequelae of that bronchial injury that happens, airway injury that happens with the inhalational thing. But when at the bedside, when you are considering these possibilities, generally, what is your approach to wean these patients and how to tackle these type of issues, sir?
these kind of things, quite a few patients we see that their lung compliance improves, but their gaseous exchange is moderate, where you do not uh, you are not very happy fully with the gaseous exchange. You try to come down on the sweet gases, you try to come down on the FDO2, but uh, after some time you have to wait. That is why I think in ECMO we put them zero sweep. If you are not very sure, for at least 24 hours you can put. If you are very sure, 6 to 8 hours is enough. So in this patient, that you after 24 hours, if you are finding that spasm, etc., and if those things are happening, it's very easy. Other couples get the lung, the patient can tolerate
Deepanjan sir, I think you are breaking.
need for your.
Deepanjan sir, actually we couldn't hear, sir. There was some internet issue. Can you repeat it, sir? Deepanjan sir, we couldn't hear you, sir, for some time, I think last, because of internet issues. Can you repeat it? Some voice issue also. So,
Yeah.
yeah, now it's better.
To wait for time and a good pulmonary try to take the patient okay. Sometimes we need to off the heart rate because of but only selective patient do not take more unless you have a good gaseous exchange and a good lung compliance.
Yes, sir. There was some break, but definitely, I think, as you said, probably these issues will keep coming in our, while weaning. Probably,
They they are common, very common. Sometimes you may find that the oxygenation is good, but the CO2 washout is not adequate. So we have to keep them on the low sweep gas levels for a couple of days and then wean off the ECMO. These things go on.
yes, sir. Yeah, I think probably sometimes.
And another problem we have faced is a chest infection, a repeat chest infection occurring when you are weaning. If the patient has a repeat chest infection, then again we have to go back on ECMO.
Correct, sir. That's what happened in our case also, sir. What happened is after that 1 week and 8 days, 9 days, when we were not able to wean him, then after 1 day, I think next day we did the bronchoscopy with the help of Dr. Gurinder Bhattu, sir. So that's what had grown the Klebsiella and then Aspergillus flavus. So I think probably there might have been development of the chest infection, which might have tilted the balance, and then he could not tolerate that. Probably that might be the thing which had we had some problem in weaning. So I think with that, actually, what Pranay sir, are you there?
Yes, yes.
Sir, in the context of inhalational injury, what do you think is your approach and any future perspectives or anything? Suppose the message that to be given to the audience. So, what is your approach? Generally, these type of patients comes. How do you go for it, sir? Like any patient who is deteriorating with inhalational injury.
So, few things you need to know about inhalation injuries. Majority of many of the times, inhalation injury comes in a not as a single patient, but might come in a multiple patients. So you have to be ready to you manage mass casualty, and then you have to prioritize who we need. Like what we have to, we got 6 patients at the same time with inhalation poisoning, and then we need to prioritize which patient needs to go on ECMO first, and then in which patient we can wait. So all 6 patients we can wait over a period of 36 hours, but then we have to prioritize. So that is one thing that you need to keep in mind. Early ECMO is definitely going to be helpful. The common findings what you are going to get is a lot of the secretions that is coming. They initially they develop with comes with a non-cardiogenic pulmonary edema. That things needs to be addressed, and then might be associated things also is going to be there. It's not going to be only the lung. If it is a burns, there will be a peripheral burns also. And if it is a poisonous gas, then the effects of the gas in general on the systemic, that you need to keep in mind. But I think the cases are rewarding. In fact, uh, the highest number of days the patient remained in ECMO was a case of inhalation injuries, which was reported at 605 days. And that case was basically a case of inhalation lung injury, and that recovered with the native lung, didn't require a transplant, but recovered with a native lung. So I think probably we need to keep that inhalation injuries becomes an important indication for an ECMO in future.
Yes, sir. There are some questions from the delegates who are joined online. So the Kondality was asking apparent ablation through which device? Yeah, in our case, we have given through machine nebulizer, but regular nebulizer is also fine. That can be done. And what are the long-term effects of the airway or otherwise the pulmonary toxicity that happens in a inhalation injury? Dr. Gandhar Bhatt, sir, you.
So it may be depend upon the severity of airway injury. If the injury of the grading system AIS abbreviated injury score, if it crosses more than 3 and 4, unlike in this particular case where we could able to revive him with near normal bronchial mucosa, but we may end up with a bronchial cast and also causing a fibrosis, just like a endobronchial tuberculosis, where the fate of disease will be depend upon the person tissue reaction and inflammation strategy. So they may end up with a collapse and fibrosis, and they may have a recurrent pneumonia because of the stenosis. So surveillance bronchoscopy in a non-responders is important to see the long-term complications and warrant the and prevent the proper complications.
Yeah. So yeah, depending upon the injury severity score, probably there may be sometimes long-term sequelae, but yeah, generally they are managed timely, probably they may escape. So I think there is one study where they looked at some 70 to 80 studies long-term. Probably most of them could not have much development of any complications. Sometimes there may be some bronchiolitis, subterraneous kind of situation, or rarely bronchiectasis, probably, but not very much. Dipanjan sir, I think one question for you from the audience, especially regarding the physiology question. So, Dipanjan sir, are you there? Yeah. So the question is like the burn patients is all they may be already having a severe SARS response, systemic inflammation and tissue stress. So their question is, should we be deliberately coming on maintaining the PO2 on the lesser side so that they will not have any hyperoxia induced secondary cellular injury? So what do you think? Your opinion on that, sir?
It's regarding the ventilatory strategy or the ECMO strategy?
Overall, the oxygenation they want to maintain on the lesser side.
See,
Compared to the regular patients.
in this patient already the gaseous exchange is compromised. Okay, so your PO2s are already down. So further down, how can it go? You cannot tolerate. And in a VV ECMO with even 100% FDO2, your saturation will not go too far high unless the lung function starts to improve. So PO2, low PO2 is itself, it is there. You do not need to target further lower PO2. Could I explain? Because it's a poor lung. So if you are thinking of just like in a cell force, not a cell force, in a paraquat poisoning where we do not give a high FiO2 for ventilation. That is causing a more of an oxidative stress and quicker fibrotic stress. In those situations, in ventilation, you keep the FiO2s deliberately low. Here, your things are not like that. Here, your stress levels are though high, your gaseous exchange through the lungs is hampered. So you have to maintain the PaO2, so that you get a good PO2 in the blood. But good in the sense that even 90 to 95% saturation with your ECMO is acceptable. Even lower than that will also be acceptable.
Yes, sir. I think
But
Yes, just to add into
I
Kalandar.
don't understand that whether if a further lower PO2 levels or saturations is going to help the patient in any way.
Pranay sir, do
Yeah,
you
I
want to
agree
comment?
with Dipanjan. I just want to add is what is going to be injured more is going to be your ventilator FiO2 of 100%. That is going to be injuring more about the lungs, and that is going to worsen the lungs further rather than the hyperoxia. Anyway, in VV ECMO, we never get hyperoxia. It is going to be usually with the best of the settings, your SpO2 does not go above 95% in VV ECMO if lung is not contributing. It goes above 95% only if the lung contributes. So you never get to go into hyperoxia when the patient is on VV ECMO. And that's the reason we try to avoid VA ECMO as far as possible. We just go for a VV ECMO. That's it. Okay. So
Correct.
hyperoxia doesn't come into existence as far as VV ECMO is concerned.
Yes, sir. As you said, that is very important. I think ventilatory FiO2 should be coming down as early as possible. That is more harm because directly the oxygen going into the alveolar level and might cause cellular toxicity, absorption, atelectasis, and all those things. Probably that is the one which we have to manage very carefully. So with that, I think probably answered. I think Gautam, do you have any doubts from your side?
Sir, good evening, sir. I have one question, sir. Sir, like as you stated, no, sir, where the patients, where they maybe have improvement in the oxygenation, but they have a problem with the CO2 clearance. So, in such patients, like what will be the role of ECOR, sir, like in such type of patients?
If you are already on ECMO,
Sir.
just wait with if you can cover the FDO2 to 21%, of 2 liters. That is the best strategy. Let a couple of days go. The lung will improve. And now the patient is free. So that the lung function improves, CO2 will come down. If you want to wean off, if you are stressed, suppose the patient has to change the oxygenator is almost not functional, but the function of the oxygenator has gone down. You have to, the patient is already on ECMO for a long time, and the patient's relatives are financially also drained off. You can think of ECOR, but the safest idea is to, if you are on ECMO, continue on ECMO with a low sweep and low FDO2.
Okay, sir. Thank you, sir.
So, sir, I think one clinical pearl from each of you, one take-home message to all the our delegates who joined online. Start with Pranay, sir.
Yeah. So the take-home message, I think, from this case scenario is basically ECMO is VV ECMO is indicated in inhalation injury, and the thing which I learned is heparin nebulization, which I never used as a heparin nebulizer. So I learned from you heparin nebulizer can be used. Okay.
Thank you, sir. Thank you, sir. Deepanjan, sir, your take home.
Take home from this case is you think of ECMO early so that you can give a lung rest early. The recovery will be faster. That is one thing. Second thing is that your physio, etc., has to be very, very aggressive so that the patient can be mobilized, secretions can be mobilized better, and you have done multiple episodes of tracheobronchial suctioning.
Yes.
So lavage is done quite a frequent times, and that is one of the things that I take back from this, that in this case it is helpful.
Dr. Gandhar sir? Yeah,
Yeah.
taken.
As Deepanjan sir said, early bronchoscopy and followed by assessment, early ECMO, sequential surveillance bronchoscopy for lavage with a simple saline, not going for the crust to repeal it off, and going for the aggressive management in terms of stenting, all those things, even after this one, not required. Support, react early, support the system, and follow with a surveillance bronchoscopy will save in this particular case. Thank you.
Yeah, another one point I actually thought of asking, sir. In our inhalational injury, even though it is severe, we didn't see much of any carbon monoxide levels and cyanides. Those things also very common. So we were looking at when once our people told like inhalation injury, I was looking at co-oximetry or ABG. Pranay sir, in your case series, did you see any patients with carbon monoxide or poisoning? The levels bit high or something like that.
They initially, yes, there was, but then usually it comes down within next in 24 hours.
Yes, sir. Generally, not much we do see that. But generally, if
You
they
don't have,
have that,
don't have to do
they may
much.
not come to the hospital.
Better oxygenation itself is a good treatment for that.
Yes, sir.
Life will be less.
Yes, yes. So I think with that, we come to the end of the session. Probably the take homes were very clearly told by our expert panelists. First and foremost, I think in inhalational injury, especially the severity may be underestimated initially. Always keep because in this patient we explained the role of ECMO need for ECMO initially only, but in that night itself he was worsening, and we could so don't underestimate the severity. It can worsen at any point of time. Another thing is regarding in airway management. Unlike any other patients with pneumonia going on to ARDS, inhalation injury, especially the smoke inhalation with soot, lot of soot, the airway management, the role of the intervention pulmonologist, repeated bronchoscopies and clearing those secretions really helps in recovery of these patients. And third point, I can say early VV ECMO. You have to consider any patient that is the most common, but inhalational injury may go to take more time, probably rather than just trying proning and all, go for early ECMO, which may make the lung going to be a better recovery. So I think with this, I conclude, and I wholeheartedly thank Dr. Pranay Oja sir, Dr. Deepanjan Chatterjee sir, and Dr. Yugandhar Bhattu sir for coming onto our board. We are very honored for that. And I thank Dr. Gautam for bringing out that interesting case with a very good lucid presentation, because of which we could have very good discussion. And I thank Yashoda Hospitals management, our branding, digital team for bringing all these sessions regularly. And I thank none other than our the audience, who the delegates who logged into our webinars regularly, and we had an interactive session. There were good questions and all. Thank you very much. Good night, sir. Good night, everyone. Yeah. Thank you.
Thank you. Thank you, Kalala.
Thank you, sir.
Thank you.
Thank you, Pranay. Thank you.